So we're going to continue with that theme on gaps in education. And so we're going to talk about another gap in medical education. My best friend in internship was a smoker. And so I watched him struggle with the habit. He wanted to quit. He desperately wanted to quit. He had 2 young children, and he would make sure that he didn't smoke in front of them. When I had my kids around, he would make sure that he would, wander away if he wanted to smoke. He wouldn't smoke in the house. He tried to quit multiple times, and just when we thought he was home free, he would relapse again. And being in internship, being in residency didn't make it easy for him. And so I developed an understanding of what smokers go through. And so when I kind of watched while we were, interviewing patients, we always asked them, do you smoke? So I'm an anesthesiologist. I'm at Yale, and we have Danielle McGlynn, who's our resident in anesthesia, and she's doing a project now in terms of figuring out whether we can do brief interventions to help people. And we have Janak Chandrasoma from the other coast, from the University of Southern California, who's also an anesthesiologist, and introducing the same type of education in his curriculum with the residents. So the premise of this whole program has been that when patients come to us, we're usually treating them for one particular issue. So they're coming to us for surgery. And so we can say, okay, I'm going to take care of them for the surgery and then let them move on with their lives. Or we can stop and we can look at them and see this patient as a whole and say, how can we make his life better than what it was when he first came to us? And what has been found is that people come in to a doctor's office for their regular visits, and you could tell them you need to eat healthy, you need to exercise. And the number of people who follow that advice is markedly lower than when a person comes in for surgery and you tell them you need to eat healthy, you need to exercise. Because at this point, they are very susceptible to advice that you give them that can actually improve their health. So we have no disclosures for this. A lot of the meta-analysis and the systematic the reviews that we are going to be talking about were written by authors who have disclosures to nicotine replacement therapy companies, and Janak, when he's talking about the evidence, will talk about it. So the way we've structured it is, I'm just going to introduce the topic. Danielle will then talk about how we've kind of tried to implement this within our own program in the preoperative clinic. And then Janak will talk about the evidence and what can you do when you go back to your own institutions. So why does it matter? As it turns out, it is the largest single preventable cause of death worldwide. It's a big risk factor for the 6 leading causes of death in the world. 480,000 deaths a year. So ischemic heart disease, cerebrovascular disease, cancers of the lung, chronic obstructive pulmonary disease. So all of them are related to smoking, and smoking has a big effect on all of them. So the long-term effects of this is that it decreases life expectancy in patients, and the associated healthcare costs reach over $400 billion. 18 to 20% of US population smokes. And these numbers are higher when you go to Russia or China. It's almost 50% of people who are still smoking. The annual quit rate is about 3 to 4%. And the importance of this is that a lot of the guidelines now emphasize using approaches to help patients quit smoking. And every intervention, every chance that you get, every encounter you have, there should be an attempt by anyone who's in the healthcare system to encourage these habits in patients. So the 5 A's, which Danielle will actually go over, we'll talk about that in a little bit. The US guidelines encourage using that. UK guidelines say we should use at least 5 to 10 minutes per year to talk about this. New Zealand has the same thing. They ask, a lot of the guidelines now have gone away from using the assess part of it. So ask, advise, assess, arrange, and assist. And so a lot of them have gone away from the assessment part of it. So again, I think Danielle will talk about that in a little bit deeper. So what we know now, we know that offering support for cessation motivates an additional 40 to 60% of people, and there's no need to screen for willingness to quit.
I'm going to talk to you a little bit about that 5 A's thing that she was talking about. More to the point, talk to you about the assess portion, which she said was not actually any longer part of the 5 A's. So the question is, wait, why not? So why is it that when we assess a smoker and see, like, hey, do you want to quit? Like, well, what's your feelings towards quitting? What's your feelings towards smoking? Why is that no longer a part of our algorithm? Well, it turns out, and I'll get into a lot of the research later, but I'll just do this portion now. It turns out that when you assess, let's say you assess somebody and they say, yeah, I really want to quit. The rates of quitting are X. When you assess somebody and they say, no, absolutely, I don't want to quit, no interest, the rates of quitting are unchanged. So it's pretty interesting, right? Because that question, which was sort of one of the 5 paradigms, the 5 pillars of smoking cessation, was figure out whether they're ready to stop smoking, is still very important. It's very important to figure out if they're ready to stop smoking. But we can't do it with a verbal assessment, because what they tell us doesn't correspond with the reality of whether they're truly ready to stop smoking or not. Does that make sense?
Yeah. You can continue. You didn't have to stop. Yeah. So this is the one that actually made me figure out, because I had all the UK guidelines and the New Zealand guidelines on it. And I just wanted to present, before Danielle goes into the details, we polled everybody who talks to patients before they come to surgery, our residents, our nurse anesthetist, our anesthesiologist, and we asked them, what do you do when patients come and do you ask them about whether they smoke? If you do ask them whether they smoke, what do you do after that answer? If they ask yes or no, what do you do? And so we had 116 completed surveys from 162 providers. And most providers say that they record a basic smoking history. They ask patients, do you smoke? But after that, 80% don't do anything. And this is common everywhere. They don't follow up with anything. 83% said that they don't direct patients to resources. But when we ask them, do you think you're responsible for doing it? 68% said, yes, we think we're responsible for doing it. And then we said, why don't you do it? If you think you're responsible and you say you're not doing it, then why are you not doing it? And 70% said, we don't know. We don't know what resources are available. We don't know what to tell patients when they ask for resources. Nobody has told them about it. And they said time, especially as anesthesiologists, we're seeing them right before surgery. 15 minutes before the surgery, we got to go talk to them, establish trust, and take them into the operating room. So people felt a time pressure. The system doesn't give them that time to spend with somebody counseling them. And 75% felt that they were more likely to counsel patients if there was an easy method that they could do, a quick method that they could use. So that is the basis of the project that Danielle is doing within our department. So I'll hand it over to Danielle.
So a number of things, what it boils down to is, and this is a really important point, whether you're a patient, whether you have a family member who's going in for surgery, or whether you're a physician, no matter what, all patients should be advised to quit before they go in for surgery. And that sounds pretty obvious, but even a few years ago, we thought that they were supposed to wait. So some practitioners are still saying, no, keep smoking. We'll work on quitting later. But we found that the benefits so outweigh the risk that really everybody should be quitting smoking before they have surgery. So most patients who smoke, a lot of them want to quit. Before surgery, a lot of patients have this increased intrinsic motivation to quit. It's what's called a teachable moment, where they seem to have a higher level of motivation to quit. And yet, a lot of them have trouble doing it. And if you look at it more generally, a lot of us have trouble making positive health changes. So we're going to talk a little bit about behavioral science. A full discussion of this topic, subject beyond the scope of this topic, but talking about some terms can help put it into context and help us understand the challenges that our patients face. So there's a behavioral psychologist here at Stanford who talks about this, and one of the things he mentions is motivation. And he describes motivation as a wave. So motivation, he says, is a wave where we spend a lot of time at the bottom of the wave, where we don't really have a whole lot of motivation. And you can see that with the blue dots on the screen. And then we have some times where we have really high peaks of motivation, and we're really able to pull together and accomplish a whole lot of things. But those don't happen quite as much as we might want. So motivation is one factor, and this can be influenced by immediate pain or pleasure following whatever we're going to do. It can be motivated by or driven by the long-term effect. Is this going to really benefit me or really harm me in the future? And it can also be determined by social acceptance. So let's say I have the goal to run a marathon. Maybe it's going to cause me a lot of immediate pain, but it's going to give me a lot of long-term benefit. And I have a new friend group, and they really like to run, and I want to be accepted by them, so I'm going to start running too. There's a trigger. So a trigger being something that sort of sparks that behavior. And there's ability. And ability is something that's often overlooked, but very important. So even if I have really high motivation to run this marathon, there's no way I can run a marathon tomorrow if I just get up and try to do it. I just don't have that ability, no matter how motivated I am. So I just want to go back to this graph, and remember, we're talking about we have these peaks of high motivation and a lot of areas with really low motivation. And our goal here is to take those moments of high motivation and use them and harness that energy to help us when we're in the troughs. If we put it all together, we have this graph. So you can see on the vertical axis, motivation. And on the horizontal axis, we have ability. And then there's a line between it that's called the activation threshold. So above the activation threshold, if you trigger the behavior, it should be able to be performed. If you are below that activation threshold, it's not going to work out. So if we go back again to running, if I try to run 26 miles tomorrow, it's not going to work no matter how high my motivation is. I'm still below that activation threshold. But maybe I give myself an easier goal, like 1 mile. I can do that. And if I have sufficient motivation, I can go out and I can actually do that. And if I have very low motivation, maybe all I really get to do that day is put on my gym clothes. So the idea is, how can we structure an environment so even when motivation is very low, we can still do something? So the idea isn't always that we can change the intrinsic amount of motivation, but we can follow the wave and we can use it to our advantage. So we want to harness those moments where we have high motivation. So that's structuring your environment and making plans for the future. So maybe I create a calendar where I have set amounts to go each day. Maybe I find a running buddy who can help me out. Maybe I set my gym shoes by the door so I see them as a reminder. And then the other part of that is learning new skills, increasing your ability. And essentially that's going to make the overall behavior easy, so my motivation doesn't have to be as high for me to accomplish the task. Really, it's all about staying in that zone of the graph where there's sufficient motivation, sufficient ability to get the job done. So, how does this apply to patients coming into our clinic? Patients who are smoking, and quitting smoking is a pretty hard thing to do. So Dr. Kerp had mentioned these 5 A's. So this is, again, what is recommended by the U.S. government. So we ask, we advise them to quit, we assess where they are. Do you have sufficient motivation that we think if we give you resources, you do something with it? And then we give you some recommendations, how can you go about this, and we arrange for follow-up. And as Dr. Chandrasoma had mentioned, people have looked into this and said, you know, this whole intervention, it takes about 10 minutes. So that's a big problem in a lot of busy clinics because patients have other problems than just smoking. How are they going to address smoking and all of these other things? And the way we can do that is by looking at this assessment step, which you mentioned. And we're going to go ahead and cut it out. A study in Denmark looked at this with 2,400 patients. And they categorized where they were in the stages of change. And they said, okay, you're the people who we would predict would do very well. You're the people who we would predict who don't. And they gave them either the intervention or not the intervention. And it turns out only 16% of the people who ended up quitting at the end of the study, only 16% were in the appropriate stage to quit. So if you actually focused on this assessment stage, you would miss a lot of people who are ready to quit. One reason that this may occur, so again, when we offer non-motivated patients assistance, they can make really big strides. And one reason that may drive us, if you remember this graph, we take somebody up this yellow dot who maybe they're doing a really hard task and the motivation is somewhere, and we're making it easier. So we recommend the 4 A's, or some people call it the 3 A's. Essentially, you're going to ask, you're going to advise, and then you're going to go through and give them research. So the first thing you want to ask is, do you smoke? The second thing is advising very clearly, you should quit. And this should be direct, it should be personalized, and you want to frame it in a positive way. And this essentially has to do with, there's some mixing of the evidence, whether gained or lost frame, meaning people see the benefits or the negatives, comes that influences patients, but it may actually help patients quit if you frame it in a more positive way. As far as what to advise, there are so many things you can tell them that you can just pick your favorites. I included a figure on here. There are many of these, and they're all framed oftentimes in these game-framed messages. One thing that's often overlooked is the financial aspect. The $2,900 a year is a pretty conservative measure if you were to smoke 1 pack a day in Connecticut. So $2,900 a year is a pretty nice vacation. Assistance of pharmacotherapy is really a good way to go. There's nicotine replacement therapy, and that comes in many formulations: long-acting patch, short-acting gums and lozenges. One's not superior to the other. It's been contraindicated in a recent MI, breastfeeding, and significant arrhythmia. They have done studies looking at it in patients with chronic CAD, and the risk of smoking itself is worse than taking nicotine therapy. So it's better to always offer this nicotine. Chantix or varenicline is the other thing. This is partial nicotine agonist. You can use it in conjunction with nicotine replacement therapy. It has no known contraindications, but does require half of the dosing in renal failure. Bupropion, this is a dopamine and norepinephrine reuptake inhibitor, and it may be more effective as nicotine replacement therapy. You want to avoid it in anybody who's at risk for having seizures, and that's going to be lower the seizure threshold, and also use caution in anyone at risk for suicide. So a range. Counseling is another aspect of this that you may not have time for in a busy clinic setting. So talking about stressors, how people cope. Those are important conversations, but they're time intensive. So the program I've highlighted here, Commit to Quit, this is a national program. It's available in every state and it's free. It's been put forth through the U.S. Department of Human Health and the CDC and through the Cessation Institute. It has 24/7 access. we know that complete abstinence is rare after a single attempt. And the average may be anywhere as low as 6 to as high as 30 attempts before quitting the smoke. So these efforts, sometimes it's a long road, but the efforts still matter, and it's the path to long-term abstinence.
So now I'm quickly going to go over some current research that we have based on all of this conversation. We actually have research of the conversation itself and this interaction with physician and with patient. Again, most of this comes from a meta-analysis, and the meta-analysis was funded, or the people who wrote the meta-analysis did have disclosures to nicotine replacement therapy companies. So I did read this and scrub through it and try to eliminate bias, which I actually did find a little bit of, but I'm just letting you know that that does exist. It's not our bias, but it's somebody else's bias for the articles we are reviewing. So the most important thing that we have to do first is define what quitting is, as Dr. McGlynn mentioned. So what does it mean to quit? So there's a difference between abstinence, where you have prolonged smoking, cessation, and quitting as an attempt that fails. And that happens because, as she said, a smoker's relationship with quitting isn't static. There might be constant quitting, relapse. What we're going for, obviously, is we're going for a state of sustained quitting or abstinence. Now, what we found is that the doctor having a conversation with a patient cannot affect abstinence. The only thing it can do is affect the patient's ability and desire to engage in a quit attempt. Now, you might be asking, if that's true, why are we doing this? Why on earth would we do that? It seems like a waste of time if all we can do is get them to attempt to quit. Well, the point that we have to make is all cessation, all abstinence starts with a quit attempt. So we're taking these people and we're giving them the opportunity to be able to quit for themselves. Quitting itself, abstinence, is a motivation thing that's internal to the person. And what they've done studies that have shown that if you don't control for motivation, just a quit attempt in a person is very rare. So I'm going to use the analogy of the same thing that doctors say when they're talking about patients exasperatively, which is you can lead a horse to water, but you can't make her drink. Okay? So you can take a horse to water, but you can't make her drink. Well, the whole point of this conversation, a horse can't drink unless you lead her to water. We're also going to talk about what I just told you and what Dr. McGlynn mentioned about assessment not being relevant in this. That is to say, the people who, as I mentioned, the people who we talked about who didn't want to quit as much as the people who did want to quit. So the horse analogy there is, it doesn't matter if you ask the horse if it's thirsty. It's not going to make a difference, because the same number of horses drink at the water, regardless of whether they say they're thirsty or not. So it's worthwhile to get all of the horses to the pond and see who drinks. So physicians hate this conversation. And the question that I have is, why are we avoiding it? Why? And studies that they've done at Yale and studies that they've done through these meta-analyses have shown that the number one thing that physicians say is time. We don't do it because of time. So as a result, every intervention that we look at right now is based on a very short model, because long models don't work because of time. Now, I'd like to throw in there, I think that every survey that they've done has shown that time is the number one response. I wonder, even though it's the number one response, if it's actually true. For instance, how many of you in this room are really good about regular exercise? Like one person. Well done, you. I didn't raise my hand. So if you ask me, okay, what's the real reason why you don't exercise? I'm going to say, yeah, I don't have the time. Exercising takes 30 minutes. I have the time. I just don't have the inclination. And the problem with these studies is time is a factor for physicians. So we can't peel that back and reveal if there's other factors there. Other factors which might be a lack of motivation, a lack of inclination. Maybe they're scared. So let's talk about the meta-analysis. So there's many arms of this meta-analysis. So first of all, there's the control, which is just no advice, no conversation. Then there's the pseudo-control. That's you give advice to the person to quit smoking. And that was compared against nothing. That was compared against no conversation. And then there's two more arms of the study. One was to take the advice and supplement it with the offer of nicotine replacement therapy. And the third arm, and compare that to just advice alone. And the third arm was advice and offer behavioral therapy, behavioral modification therapy, and compare that to just advice alone. So let's go over the results and see what we know in the literature is true. So it turns out, as compared to nothing, compared to no conversation, advising somebody to quit and giving them resources increases the frequency of quit attempts dramatically and increases the rate of abstinence. So it's a really good strategy to at least have the conversation with your patient. Now, let's look at the other arms. This is where it gets interesting. So nicotine replacement strategy, if you look at total numbers, dramatically increases abstinence rates and dramatically increases the likelihood of making a quit attempt. So both quit attempts and abstinence, the numbers go up. But if you peel it back and look a little bit further at the numbers, it's a little misleading. Because what you see is the quit attempts go way up, but the ratio, or the ratio of people who make a quit attempt to people who abstain remains exactly the same. So what we're doing is we're driving up quit attempts dramatically with the nicotine replacement. Again, just like I said before, doctors can't change abstinence rates. And in fact, nicotine replacement doesn't change abstinence rates. But it's kind of like the horse thing, right? Nicotine replacement doesn't make a horse drink any more reliably. But nicotine replacement is great at leading horses to water. So if you lead double the horses to water than you previously were, more horses are going to drink because there's more horses at the pond. It's the same thing with behavioral assistance. So behavioral assistance provides the same benefit, which is that you don't get a change in the rate of people who abstain after making an attempt. But overall, the numbers are better because you're driving up those quit attempts with behavioral assistance. So how do I use this in my practice? So it's interesting because when I have the conversation with my patients, I actually talk about the data. The first thing I say is, look, there is something that is necessary but not sufficient to your quitting. It is a crucial component of your quitting, and that is you have to want to. There has to be motivation. Now, wanting to is different than knowing you should. Wanting to is different than your spouse or your kids don't want you to. You have to internally want to. And if you internally want to, you have a chance. It's not a guarantee, but you have a chance. Then I go through some behavioral components. I obviously tell them before that smoking is really bad for you. I open with a little bit of a joke. They say, oh yeah, I do smoke. I say, how many packs a day, how many years? And then I say, I read somewhere that that's pretty bad for you. And then I tell them, it's actually really bad for you. And I talk about it increases your rates of cancer, increases your rates of heart disease. But really, the thing that's really scary to me is emphysema and COPD. Because the idea that I couldn't breathe would be really dramatically scary. And I tell them that, and then I go on to say things that I've said. And I finish by saying, it's interesting, but I wouldn't go cold turkey if I were you. I don't want your quit attempt to fail. So why don't I try a little behavior modification, which was the third arm of that study. I say, if you smoke a pack a day, why not make an effort tomorrow in throwing away the pack with one cigarette in it? That's your goal for next week. Next week, every day next week, you're going to throw away the pack with one cigarette in it. And the next day, and the next week, you're going to throw away the pack with 2 cigarettes. And the next week, maybe you go to 3. It won't be quick, but I'm trying to behaviorally modify them to want to quit smoking and feel empowered to be able to quit smoking. So in summary, everyone should quit. Now, Dr. McGlynn mentioned that sometimes in anesthesia we used to tell people, oh yeah, keep smoking. The reason for that is actually it's pretty interesting. Your risk in surgery actually goes up a little bit if you stop smoking too early before surgery. So if you stop smoking 3 days before surgery, your risk actually increases a little bit. But it doesn't matter. Because what we've learned is, from all of this data, you should never tell a smoker not to smoke. You should always embrace and engage this opportunity to tell people it's time to quit. Keep it brief. Use the 4 A's. You can prescribe pharmacotherapy or behavioral therapy, and you always have resources yourself that you can go to if you don't know about them. Thank you. Any questions that anybody has? Hang on 1 second, love. He's going to bring you a microphone. I want everybody to hear.
Is there any anecdotal information or better yet, data involving the other countries like China, Russia, etc., versus other countries?
The data that I've looked at, there's some data from Australia, there's a lot of data from the UK, there's a lot of data from the United States. I haven't personally seen anything from Korea, China, Russia. I haven't seen that data. But then again, I haven't gone necessarily looking for it. Do you guys know of anything?
So now we've reached the point here in the US and in the UK where it's uncool to smoke, so that we don't have the youngsters getting into the habit. But we haven't yet reached that in any of those other countries. So we still have a higher prevalence of it. In this particular population, I have not seen studies that have been done to see whether in this population, whether helping them, having interventions, what their rates are. But it's a good question. We'll go back and look at it.
I know my mom tried to stop smoking for years because she had an association of, I start cooking dinner, I'm going to have a cigarette. I get in the car, I have a cigarette. So do you work with sort of breaking those links of activity to cigarette smoking too, or is that a whole different thing?
That would be sort of like, for her, it's almost like that trick. That association is her trigger. So what you can try to do is pair it with something new, and preferably you want to pair it with something that you like to help you have a preference for that other association.
And that's mostly what they try to do in behavioral therapy, is to actually identify what is it that makes you want to do it. Most of the times it's, you come out and you have nothing else to do, okay, you light up a cigarette, And I think that when you change that, instead of doing that, you do something else, And if once you associate that time of the day, or you associate that thing that happens with another outcome, I think it makes it easier for people to quit. So, there's a lot of professional counseling that is available to people who want it, and I think directing people to those resources is, another thing at which we fail. As physicians, we fail to do that.
And it's very difficult, not only for those associations that people have, but also their relationships. And sometimes we're asking people to change your social relationships. Maybe you really like to go out with your friend, and especially young people who go out and they'll smoke and they'll go out with their friends, or maybe it's their significant other. And to ask somebody to create that tension in their relationship is a hard thing to do.
So have you looked at how to affect motivation? Clearly, it's a motivation.
So motivation is very much an internal thing, and it comes from, we don't know where it comes from in regards to new spirituality, new relationship, birth of a child. Important real life things affect motivation, and as a scientific community, we have been utterly unsuccessful in touching motivation, even a little bit. Real, true motivation, utterly unsuccessful. As I said, the best thing we can do as a scientific community is to try and affect quit attempts, because we don't touch motivation. We don't touch abstinence. We don't touch motivation. We can't. We would love to, and I don't know if you guys have any further comments on it. But
well, I think the gain-framed messages that we were talking about, because one of the things that smokers hate is when physicians blame the diseases they have on their habits, and that probably affects their habit negatively. So rather than trying to help, to motivate them to quit, it actually motivates them to stay away from physicians. So it's, if my physician's telling me something that I don't want to hear, I'm not going to go there. And I think that that's where where we can make a change, is where we can change those messages to actually affect them positively, to tell them how their life can change positively and not blame for what they've done, what has happened so far. So I think in terms of changing that is where we can actually make a difference.
And to clarify, it actually, studies have shown that having the conversation about quitting smoking is not something that patients necessarily resent. It's something they expect, and it didn't decrease their coming into the doctor. But when the doctor said, like you said, when the doctor said, oh, you have lung cancer, well, I mean, we all know why, that was something that was a driving wedge between the relationship. And it's funny, because doctors actually thought that was the one safe time to talk about smoking, and it's kind of the one time that you should.
And to go back to something that you had just said, so like, we can't necessarily budge motivation. We don't know how to do that yet, but what we do know are these certain moments where the motivation seems to be elevated, and that's what we're trying to do with these surgeries. We know that around the time of especially major surgery, there's significantly higher quitting. So the annual quit rate's 3 to 4%, but when you put it in a surgical population, but 10% of them, it occurs in the time of surgery. So
and it changes with the type of surgery.
Mm-hmm.
So if patients are having an open heart surgery, the amount of people who quit at that time is 50%. If they're having angioplasties, it's 33%. And if they're having angiographies, it's 18%. So it changes with the type of surgery too, which is very strange, because I think it's at that time, that motivation that you were talking about, it changes because of people's perception of how important this is in their lives. And what we can do is to harness that we can't create it, but when that happens, we harness it. We use that moment to see whether we can improve the patient's life for the better.
And in regards to motivation, it's interesting because I think that social norms help. So a perception that we can create in society of, oh, smoking is bad for you and it's not that cool, other people aren't doing it, most people don't smoke. Engaging people in social norms actually really helps.
Mm.
Those are
Absolutely.
So what you're talking about would be, in that behavioral model we discussed, that's the trigger. So kind of like what you're saying, there's a sale. You're walking down the street, you see the sale, and you're like, ooh, I want that. They're using that to trigger you, but they talk about that separately from the actual motivation. So the trigger has to be in a setting where you're sufficiently able to get the item. So you have to have enough money to buy the sale item, and you still have to have enough motivation to go into the store and go get it.
And one of our problems is that the doctor's office is a time where they're expecting to have it, but it's not necessarily coinciding with their motivated points. But one of the benefits is The
Yes,
pre-surgical visit is absolutely coinciding with one of their high motivation points, which is why we're giving you this talk.
I don't know whether physical. So the
Like
problem
cigarettes?
with the problem with incentives, that's a very tricky situation. It happens all the time. So I'm in charge of the medical education in my department, and people say, oh, why don't we tell them if you study this, you'll get a gift card. And the problem is afterwards, people will associate the completion of that task with that reward. And you want it to be for the right reasons. You want people to learn for the joy of learning. If you want to do that, then and you give them a gift card, then when you stop giving the gift card, they'll stop learning. So it's very, very tricky, and I always struggle with that. And then there's also the punishments. Sometimes they want to give punishments. They want to put people on extra call, and so what it creates in people's mind is that call is bad. And that's not good, right? You don't want people to associate being on call with a negative, to have a negative connotation. So I'm always very, very careful in, especially when you're dealing with trainees, to make sure that you're aligning your incentives and punishments right, because otherwise you're going to create that mindset that this is what we are working towards. So just like that, if I tell you you're going to quit, I'll give you $5. When you stop giving them the $5, they're going to go back to cigarettes. They're like, nobody's paying me anymore, so I'm going to go back. So that's, and I think that doing it for the right reasons and doing it for themselves are the ones that are actually going to, make it go long term towards abstinence.
I came in late, so I apologize if you already answered this, but what's the timing that you give the message to the patients preoperatively to stop smoking? When do you do that? How do you get in front of the patient? What's the ideal time? I'm an anesthesiologist, so I like 2 weeks.
Correct.
And,
so the studies they've done, it's gone all the way from 4 weeks preoperatively. So when they've done those randomized controlled trials where they've done 4 weeks preoperatively, and they followed them 4 weeks post-op. A lot of us don't see patients 4 weeks preoperatively. Many of us for major surgeries will see them probably 2 weeks preoperatively. They've said that any time you see them, even if you see them on the morning of surgery and you tell them, so now I've changed my practice and we're changing our practice in our department to actually any point of contact that we have, what was missing was the training. Right? We didn't know what to do. Once a patient said they're smoking, we are like, okay, what do you do after this, right? I don't know what resources to guide them to. I don't know what to tell them about quit attempts. But what Danielle is doing in our preoperative clinic is designing this short intervention and then training people who are in the preoperative clinic on this, like 3 to 5 minutes is what we think. Because if you design anything more than that, people are checked out. They're like, we're not going to do this. So we want to make it as effective. Is this like the Oscars where they stop you when your time is done? They cut your mic,
One follow-up. Is there any attempt at all, about subliminal messaging during an operation?
Oh, we make fun of it. We're like, we got to put headphones and say, you will stop smoking. You don't like cigarettes,
Have you
So.
looked at that or no?
IRB approval would be really hard.
That IRB will be very
Yeah.
tough when you start with the supplemental messaging.
So we are a little past time, so we're going to questions.
Okay, people come up for questions.
I was going to say, I'm pretty sure all the panelists are going to be gracious enough to answer them after the fact, but if we could please thank the last 3 panelists.